Let's start with the definition of asthma. Asthma is a chronic airway disease that is both obstructive and reversible. It's characterized by chronic airway inflammation or swelling of the inside of the airways, bronchial hyperresponsiveness or constricting of the muscles outside of the airway, and hypersecretion of mucus from irritation. Risk factors for developing asthma. Risk factors for developing asthma can be broken down either into an allergic response and environmental triggers. The allergic response, or atopy, seems to be the strongest identifiable predisposing factor for developing asthma, with atopic dermatitis often preceding its onset. Infants who become sensitized to food allergens early in life have an increased risk for developing asthma. Most children with asthma are atopic, but not all atopic children will develop asthma. Inhaled allergens are believed to be the most important factor in the onset of asthma in children predisposed to atopy. Environmental triggers. There are several significant indoor environmental triggers. Once an aggravating agent is identified, such as animals, feathers, molds, pollen, cigarette smoke or dust mites, it is essential that the household undergo an intervention that could remediate or eliminate the trigger. Tobacco smoke is closely linked with increased asthma prevalence and morbidity, and it is important that the patient or others around who live in the household refrain from smoking. Smoking cessation measures are suggested. If there are smokers in the home, it is important that all smoking take place outside, away from the home. Cockroach exposure is another concern that affects patients who live in the inner cities. Cockroach antigens are commonly found in the bedrooms of children who are sensitized. It's important that the family practice routines that include not leaving food exposed or the garage open, and putting in place cockroach elimination measures such as poison baits, boric acid, and cockroach traps. Molds are another common trigger in the home. Once identified, it's essential that the mold be cleaned up and the area dried out. This is a particular problem in humid environments like Washington State, or where there are plumbing leaks that are left unattended. House dust mites are another trigger. To manage this problem, it's recommended that mattresses and pillows be encased in allergen-proof covers. It's also advisable that the bedding be washed in water that is warmer than 130 degrees Fahrenheit. Other suggestions are to reduce stuffed animals to the bare minimum, limit them to one, and wash. Much research has been devoted to the relationship between wheezing illnesses in infants and the development of asthma. Respiratory syncytial virus is one of the most common viral respiratory tract pathogens isolated from infants who wheeze. Many infants with severe infection with respiratory syncytial virus or RSV develop recurrent wheezing and asthma later in life. Next, we'll talk about asthma education and prevention. The National Asthma Education and Prevention Program was formed in the 1980s by the National Institutes of Health. It was formed to assist the promotion of asthma education to the public, healthcare professionals, and to patients. The most significant undertaking of this organization has been the development and dissemination of the Expert Panel Report 3, Guidelines for the Diagnosis and Management of Asthma, published in 2007, or known commonly as the Asthma Guidelines. These recommendations state a few goals of asthma management, including prevention of chronic asthma symptoms and minimization of asthma exacerbations using the least aggressive therapy needed, maintaining of normal activity levels, including exercise, physical activity, and avoiding missing school activities, maintaining a normal pulmonary function test, preventing recurrent asthma exacerbations, and minimizing the need for trips to the emergency room or hospitalizations, providing optimal pharmacotherapy with minimal or no adverse effects, and meeting the patient's and family's expectations of and satisfaction with the asthma care received. A thorough history includes descriptions and frequency of previous exacerbations, hospitalizations, number of emergency room visits or unscheduled doctor's office visits, and amount of school missed because of symptoms, as well as response to previous therapy. A physical examination of the upper respiratory tract, chest, and skin is vital for the diagnosis of asthma as well as to rule out other disorders. However, examinations may be completely normal between acute exacerbations, and the medical history is a stronger factor in supporting a diagnosis of asthma. Pulmonary function testing is used to help confirm the diagnosis of asthma. It's also used to estimate the severity of airway inflammation and follow the response to changes in therapy. Because all pulmonary function tests are effort dependent, children must be old enough to correctly perform the PFT and provide maximum effort. Some children can follow directions for a PFT as young as 4 years old. Most others are able to accomplish this at 7 or 8 years old. Exhaled nitric oxide, or NO, is a known biologic mediator in humans and is produced by the lungs and present in an exhaled breath. The fraction of exhaled nitric oxide, or FeNO, is a quantitative, non-invasive, simple, and safe method of measuring airway inflammation in patients with asthma. According to the ATS Clinical Practice Guidelines, a patient with a low FeNO level of less than 25 parts per billion is considered less likely to respond to corticosteroids than a person with a FeNO level of more than 50 parts per billion. Those who are intermediate are considered between 25 and 50. Bronchial provocational challenges. Bronchial provocational challenges can include exercise, cold air, hyperventilation, or methcholine. Methcholine and histamine are the most common pharmacologic agents used for bronchial provocational challenge. The challenge is performed in a medical facility with a physician present and a CPR cart. Differential diagnosis. Asthma is one of the most common causes of recurrent or persistent wheezing, cough, and shortness of breath in children. However, several diseases and conditions can mimic asthma. It's important that a thorough history, including response to prior treatment, physical exam, and data from additional tests can help to differentiate asthma from other disorders. Some of the other conditions that mimic asthma are upper airway disorders, cystic fibrosis, pulmonary embolism, aspiration syndromes, and aspiration pneumonia. Management of asthma. Let's talk about the drugs that are taken by asthmatics. These are drugs that you'll see frequently as a respiratory therapist. Some of the pharmacologic therapy used for asthma are long-term control medications and quick relief medications. We'll also talk about how these medications are delivered. First, long-term control medications. Long-term control medications include inhaled steroids, which are the most consistently effective controller medication for asthma and are considered a first-line therapy for treatment. Long-acting beta-2 agonists. Long-acting beta-2 agonists, or LABAs, are available in the United States in the form of salmeterol and formoterol. Salmeterol is available alone as a dry powder discus. It's also available in a dry powder discus in combination with the corticosteroid fluticasone. Formoterol is available as a dry powder inhaler, alone, or in combination therapy with the most recently in a liquid form for nebulization. The biggest difference between the two long-acting bronchodilators is their onset of action. Salmeterol can take from 30 to 90 minutes to have a peak effect, whereas formoterol begins to take effect in 3 to 5 minutes. Evidence on the use of LABAs in asthma has demonstrated that the addition of LABAs to the treatment of asthma not well controlled on low or medium dose inhaled corticosteroids improves lung function and diminishes symptoms. Methylxanthines. Although theophylline at one time was a prominent component of daily asthma treatment, its role has changed over the past 10 years. It's now listed as an adjunct therapy to inhaled corticosteroids, but it's not preferred. With the current focus on anti-inflammatory therapy for asthma, along with its narrow therapeutic window, the need for close monitoring of serum levels, theophylline has limited use in the management of asthma for children. Leukotriene modifiers. Leukotrienes are a potent pro-inflammatory mediator that promote bronchospasm, mucus production, and airway edema. Leukotriene modifiers are a new class of medicines for asthma treatment in the last 20 years. Leukotriene action is modified by agents that either inhibit the production of the leukotriene or block their action. These agents are relatively new, and more studies are needed to determine their role in pediatric asthma care. Palladium and netochromolin are stabilized mast cells that can interfere with chloride channel function. They are used as an alternative but not preferred. They can also be used as a preventative treatment before exercise or unavoidable exposure to known allergens. Immunomodulators. Omalizumab, OMALIZUMAB, is the only drug that specifically binds circulating IgE and is indicated for moderate to severe asthma in patients that are older than 12 years old, who had a positive skin test or positive in vitro test for INS. Let's talk about the quick relief medications. Medications in the quick relief category are short-acting beta-2 agonists, or SABAs, anticholinergic agents, and systemic corticosteroids, those corticosteroids given orally or by IV. All patients with asthma need a quick relief medication, preferably a short-acting beta-2 agonist, to take as needed for acute symptoms. One of the most well-known short-acting beta-2 agonists is albuterol. It has a rapid onset of action in 5 to 15 minutes and lasts for 4 to 6 hours. These are often referred to as rescue medications. They are used only on an as-needed basis, not part of regular scheduled medication regime. Increased use of these agents, particularly more than 1 canister per month, is an indication that asthma control has not been achieved, and asthma is increasing in severity. Some of the most common side effects of these medications are tremor, palpitations, and tachycardia. Anticholinergics. Ipratropium bromide is the anticholinergic agent approved for use in the United States. It is available alone or in a metered dose inhaler and nebulizer formulation. Given alone, it is much less effective than short-acting beta-2 agonists such as albuterol or levobuterol. The combination of ipratropium bromide with albuterol is marketed in an MDI and nebulizer unit dose preparation. Systemic corticosteroids. Patients with acute asthma exacerbations, such as those seen in ER or ICU, are often receive a 3 to 10 day burst of prednisone or methylprednisolone. The bursts are primarily used to hasten recovery and prevent recurrence of symptoms. The dose of corticosteroid is tapered as symptoms resolve. However, if symptoms return within 1 month, or if the bursts are frequently required, changes are likely needed in the long-term control medication regime. Let's talk about how these are delivered. Asthma medications are usually given through inhalation in an aerosol form. Medications are administered by metered dose inhaler, dry powder inhaler, or liquid small volume nebulization. Valved holding chambers are simple, inexpensive, and they've been developed for use with metered dose inhalers. Their purpose is threefold: to slow aerosol velocity, minimize particles that impact in the back of the throat, and to enhance the deposition of particles into the lower airway tract. Their use in children is recommended to reduce the problem of coordination of actuation. Studies have demonstrated that the decrease in pharyngeal deposition results in improved drug efficacy and a reduction in local side effects such as thrush. This is a picture of a home nebulizer unit. Here are 2 different kinds. Here is a picture of a metered dose inhaler with a spacer, with a face mask. Pictured here is a typical flow chart that a respiratory therapist may use for treating asthma in the ER. As you can see, it can result in either admitting to the ICU, mechanical ventilation, giving SABAs, or IV steroids. Repeat assessment is required, and response to medications given must be assessed. With poor response, patients will be admitted to ICU if the symptoms are severe. With a good response, a patient may progress and be able to be discharged home. With an incomplete response, observation is suggested for 4 to 12 hours. Management includes control of triggers. The parents must be able to identify what the child is allergic to and then put in place avoidance and control measures. Because childhood asthma is often exacerbated by an allergic response, it's helpful to identify what is causing it. Allergy skin testing, along with a thorough history and physical exam, is one method an allergist uses to determine which allergens may be aggravating a child's asthma. Another common test used to determine what allergens are responsible for allergic disease is a RAST test, or radio allergosorbent test. Once the allergens have been identified, avoidance and control measures can be put in place. It's nearly impossible for a child with asthma to avoid all exposure to allergens and irritants, but it's possible to minimize exposure to them. This begins with teaching the child and family to recognize what triggers the allergic response and use measures to control and avoid those triggers. Immunotherapy. Allergen avoidance can only produce changes in asthma disease activity and bronchial hyperresponsiveness. Often, there is no practical means of avoiding exposure to all allergens. Allergen immunotherapy or allergy shots should be considered for asthma patients when the following conditions are met. There's clear evidence of a relationship between asthma symptoms and an allergen exposure. The patient is symptomatic during a major portion of the year, and symptoms are difficult to control with drug therapy. Another tool in asthma management is the peak flow meter. Several different types of peak flow meters are pictured here. Peak flow monitoring is best when a child is at least 4 years old or older. They must be able to follow directions, make a tight seal, and do a short, quick breath, like blowing out a candle. A peak flow meter is relatively inexpensive. It's used for ongoing monitoring and not to diagnose asthma. It's best when they keep a peak flow diary. Peak flow should be done in the morning and at night, and keeping a diary or chart of readings is an important part of their treatment plan. Plotting peak flows are often included with the peak flow meter and can be photocopied for additional use. There's also smartphone apps that can help patients and children track their progress. With daily peak flow monitoring, a patient may see a drop in peak even before severe symptoms are felt. This may lead to early treatment or to seek medical help. It may also prevent an asthma exacerbation from occurring, or at least lessen the seriousness of the episode by medicating at the first sign of a low peak flow reading. Personal best reading. There are predicted normal peak flow values that are determined by height, age, gender, and race. However, it's necessary to determine a child's personal best peak flow reading. This is defined as simply the highest or best measurement obtained when a patient is free of symptoms and asthma is under control. Peak flow zone system. Once a patient's personal best peak flow has been established, every effort is made to maintain the peak flow values within 80% of this number. One peak flow monitoring system uses a zone system to indicate asthma severity and guide patients in an appropriate response. Green, yellow, and red zones are established. A green zone is 80% or better of the personal best. The yellow zone, or caution, is 50 to 80% of the personal best number. The red zone is anything at 50% or less. This is the danger zone and means that exacerbation is severe or that asthma is poorly controlled. This is a child using one of the peak flow meters. Asthma Action Plan. An asthma action plan with information that patients can immediately refer to should they become symptomatic is appropriate for school, home, and for physicians. Both the general practice and a pediatric pulmonologist should be aware of the asthma action plan and be able to make modifications. More important than the action plan itself is that the patients and parents understand the action plan fully. It's based on the patient's current peak flow reading S number. If the child is young enough, it may be based on symptoms. Patient and family education includes education on the asthma disease process, medication skills, identification and control of trigger, and self-monitoring techniques. Key points concerning the disease process include a basic understanding of what asthma is and what can trigger asthma episodes. Medication skills include being able to effectively use metered dose inhalers, dry powdered inhalers, or nebulizers, depending on what the patient is taking. Identification and control of triggers. Patients and family need information to be able to tell what triggers asthma for the child and ways to avoid those triggers. The patient and family should be urged to take all necessary steps in order to avoid the triggers and learn how to monitor which triggers influence their symptoms most. Self-monitoring techniques. Patients must learn to monitor and recognize signs and symptoms of worsening asthma. Education in the proper use of a peak flow meter and how to follow an asthma action plan is an essential part of asthma education. Reinforcing appropriate behavior includes reviewing peak flow monitoring, inhaler techniques, and implementation of the action plan. Review of the action plan at each visit has been shown to improve patient compliance and diminish the chance for confusion. As the patient gets older, the patient can assume more and more of the monitoring and treatment. Managing asthma in the ER department. Patients presenting to an emergency department have often had previous ER admissions and hospitalizations for treatment of severe asthma. Often, these patients have no primary care physician and rely on symptomatic control and emergency departments as a primary source of their medical care. Along with inadequate use of inhaled corticosteroids, these characteristics are often associated with an increased risk for fatal asthma. Assessment. The intensity and progression of asthma exacerbation can vary and will depend on the intensity of the treatment in the ER. It's vital that a primary classification of severity can be determined in the emergency department. On admission, a physical exam is performed along with a measurement of oxygenation and airflow. A pulse oximeter is used to measure oxygen saturation, and continuous monitoring of oxygen with a pulse oximeter is crucial to prevent desaturation. A peak flow meter or spirometer can provide assessment of the severity of airway obstruction from inflammation and bronchospasm. However, during a severe attack, a peak flow may not be possible. Intensive medical therapy is indicated. Beta-2 agonists. One of the first lines of therapy is a beta-2 agonist or short-acting bronchodilator. These can be given every 20 to 30 minutes either by nebulizer or metered dose inhaler. If the patient does not respond to this treatment, continuous nebulization may be started, and in severe exacerbations, the addition of ipratropium bromide to the beta-2 agonist should be considered. It's critical that corticosteroids be given to treat inflammation that occurs during an acute asthma attack. Early treatment, which may include the use of IV corticosteroids, is effective in preventing an increase in the severity of symptoms and may avoid hospitalizations. Because IV lines are uncomfortable and can be difficult to place in a child, studies have investigated the use of oral delivery of corticosteroids in the emergency setting and have found that oral administration is as good as the IV route. If a child cannot adequately be given oral steroids, the IV route should be considered. An adjunct therapy in severe asthmatic attacks is also intravenous magnesium sulfate or Heliox. Criteria for hospitalization includes poor response to 4 hours of bronchodilator therapy, requirement of a continuous bronchodilator therapy, previous visit or ER department within the last 24 hours, hospitalization for asthma within the last year, previous hospitalization with admission to the intensive care unit for asthma, history of mechanical ventilation for asthma, poor access to medical care, or recent increase in the need for oral corticosteroids. Asthma in alternate settings. We'll talk about exercise-induced bronchospasm, or EIB, asthma at school, and asthma camps. Exercise-induced bronchospasm is also called exercise-induced asthma. It begins usually during exercise and tends to reach its peak 5 to 10 minutes after a child has ceased physical activity. It can be worse in cold weather and may take another 20 to 30 minutes for symptoms to spontaneously resolve. EIB is caused by a loss of heat or water from the airway during exercise. This is often caused by hyperventilation of cool or dry air. The diagnosis of EIB is based on history that is compatible with asthma symptoms that occur with or directly after exercise. An exercise challenge test can be performed to confirm the diagnosis. To manage EIB, a beta-2 agonist is typically given 5 to 60 minutes before exercise and preferably closer to the start of exercise if possible. Outdoor activities may need to be adjusted if the conditions outside are unfavorable, such as cold, wet, rainy, or a high pollen count. Asthma at school. 1/3 of people with asthma in the United States are younger than 18 years old. Dealing with asthma at school can present challenges for the child, the parents, and the school personnel. Asthma symptoms can interfere with many activities that the school-age child wishes to pursue. Asthma is the leading cause of school absences, with an average of 10 days per year and up to 30 days per year with severe asthmatics. School personnel, including teachers, coaches, and nurses, need to become familiar with the early warning signs of an impending asthma attack and what to do if the symptoms persist. It's recommended that a copy of the child's asthma action plan be kept at the school and that the teacher and school nurse are familiar with the plan. Unfortunately, many school systems only have a part-time nurse. Therefore, there are occasions when the nurse is not available and other school personnel need to step in to provide care for the child. It's essential that the asthma action plan, peak flow meter, and rescue medications be accessible to the school staff. Asthma camp. In recent years, there's been a growth in the number of asthma camps available for children. These camps offer children with asthma an opportunity to spend time with other children who have the same disorder. This type of experience can be priceless. The camps are structured to assist children in recognizing symptoms and how to respond to them, with particular attention to the use of an asthma action plan. Identification of triggers and avoidance techniques are discussed as well. The proper use of medication delivery devices and peak flow meters is also reinforced. Positive effects from attending camp include a reduction in the rate of post-camp hospitalizations, school absences, and emergency department visits. The camps are usually operated with a team approach that includes physicians, respiratory therapists, social workers, and nurses. This is the end of our presentation on pediatric asthma. Thank you for your time and attention.